And I guess we can record her welcome slide. So that helps. Thank you. Okay. So let's look at the, I think, next agenda item. And so it's great that Dr. Bauer is with us today. At our previous meeting, Dr. Bauer presented the University of Maryland Consumer Health Information Hub. And Dr. Bauer, I don't know if you have any updates since our um, last month's meeting, or any points, a few points that you might want to provide just in terms of updates.
Only just one thing. So I think particularly because the Prince George's Coalition is so large, the overall coalition, I think it has 400 plus members or maybe more. Um, one of the things that I think is, we talked about this when we were in a different role providing the technical assistance to the local coalitions, but I think under the hub, this becomes even more critical, is using that entire network within the coalition to kind of really ramp up information diffusion within communities. So I think we're thinking more actively about how to do that. I mean, I know that COVID kind of stimulated that with the vaccine distribution. And I keep coming back to that all the time as a model about how that group on Monday came together somewhat
Mm-hmm.
spontaneously, but maintained itself for, I think, a couple of years, where every Monday people were getting together at 11 a.m. to talk about both the vaccines themselves, but information dissemination about the vaccine. And I just think that's
Mm-hmm.
such a great model for other topics, and really thinking about, how active we should be in diabetes information, heart disease information, STD screenings, like opioid prevention. There's just a lot of topics where I think there's existing information. It there's no kind of like strategy and focused effort on dissemination. So I'm hoping that we can continue that conversation with the coalition, because this particular coalition has such a big network.
Yeah, absolutely. And I think it would be interesting to pinpoint maybe a couple critical topics, which diabetes is certainly one of them. To have to, maybe to say we're forming a group, or do we need to form a group to do one of these things that you listed.
Well, and maybe we'll create like a county level, information dissemination challenge. That won't be its name. We'll come up with a better name than that. But I'm always pointing this out to my students, is like in public health, like we create these great informative materials, but then we don't put nearly as much effort in getting them out and kind of saturating the community. And we don't do it repeatedly, right? So in communication, we know like in a virus, you don't want to be exposed at all. But in communication, you want to expose people over and over and over again to your messages. And so I think we forget how much work it takes to really kind of saturate a community, so that no matter where you go in Prince George's, you're getting information about diabetes, for example, and
Mhm.
diabetes prevention, and what can you do, and what are the programs, and who can you talk to, and where can you get help. It's like having that, maybe that we should have a county by county challenge and see who can really show be that exemplar for how you really saturate a community, so that everybody, because it's an equity issue, right?
Mhm.
It's an equity issue if only some people have that information and the majority of people don't.
Mhm. Absolutely. Absolutely. Wow. We need to have you come back, and we should talk about this. I like the idea of a challenge. Competition. No.
Yeah, maybe we'll have a little competition with some prize money.
Yeah. Ooh, that's even better. Can we participate? Okay. So thank you for those updates. And then we also talked in more detail at the last meeting about the Health Equity Champions curriculum program. and kind of comb through that. And we actually prepared the document that we turned over to the students at the Terrapin think tank. So they are going to join us later in today's meeting to give us some updates of where they are in terms of uh, looking at the program and helping to shape the program. So taking all of that work that we've done, that preliminary work that we've done, and really working to shape a program that can be implemented. So those are the updates on all. I think I've covered the key points. And we reached out to Dr. Hancock. We are hoping that she can join us again. She may be involved in this meeting that's taking place today. So hopefully she will be able to join us at another meeting soon. We had someone that joined us, RC. Would you like to introduce yourself in the chat?
Hello, my name is Regina Clay. I'm from Care First.
Oh, great. Well, welcome. Is this your first meeting?
It is my first meeting. I think I was invited before, but yes, this is my first meeting. Trisha Swanson from our team used to attend before previously.
Well, we are so, yes, I remember the name. So we are so pleased to have you and welcome to our meeting today. You're just in time to get some, I think, really great information. We're going to have the students from the University of Maryland Terrapin think tank after our presentation. So they'll be joining us in a minute, and they will kind of give you some updates too about some of the things we're doing. So
wonderful.
Yeah. So
thank you for having me.
You are welcome. Thank you for being here.
Okay. So looks like we are having a great information, just as Phyllis had mentioned, with the community health assessment. And Jake, who is the manager for the Office of Assessment and Planning for Prince George's County, he will be providing and sharing that information for us. I believe everyone should have also received about the 200 plus page document for the community health assessment. So please feel free to review that at your leisure. But at this time, Jake is going to kind of give us some of that information, compressed information, so that we can digest it and then have a discussion. So I will turn it over to you, Jake.
Good. Yeah, so I will give a brief kind of overview.
Jake,
yes.
Sorry, could you project this presentation because it can be a little bigger for us so we can see better? Certainly. Now that you're going to put data out there for us to see. Great, thank you.
Can you see that okay?
Yes, we can. Yes.
Perfect. All right. So yeah, I will just kind of give an overview of the community health assessment. So some of these slides may be a little repetitive. I think I presented some of them at the overall coalition meeting, but then we'll kind of dive into a little bit more information about the actual population of Prince George's County and what we have available data-wise. So just kind of a quick overview for we had a core team of planners that basically was Prince George's County Health Department and then the hospitals. And then coalition members were heavily involved as well. And we had 4 priority areas: social determinants of health, behavioral health, obesity, and metabolic syndrome and cancer. And those are kind of left over from the 2019 community health assessment, because there wasn't a whole lot of time to reprioritize during the middle of COVID. But kind of their thought process and the goals for the community health assessment was to maximize community input, And that meant from both residents and community experts, both key informants and partnering organizations. And it was a focus on utilizing existing data, and they used the mobilizing for action through planning and partnership framework. And that's just a very interactive framework that makes sure that you're engaging a number of different partners and stakeholders throughout the process. So some of the key findings were that the social determinants drive many of the disparities, and these were further exacerbated during the pandemic. I don't think that would come as a surprise to anyone. Access to healthcare is still kind of the leading issue identified by the residents and the stakeholders and the community experts as the #1 priority there. Another thing that really came up was the desire for more permanent solutions and not temporary resources. And then that the disparities in health outcomes are pretty complicated for Prince George's County. The key findings from the chronic conditions are obviously #1, and they continue to lead in poor health outcomes for county residents. But behavioral health needs often overlap with other systems and are compounded by other unmet needs like housing and other social determinants of health. So it's really difficult to separate out those issues entirely. The population is growing and also aging, and while many issues have been improved, there's still significant disparities. And I think we'll see that even more in the next community health assessment when we have some of that data from the time during the peak of the COVID pandemic. So the recommendations were to leverage the attention from COVID to address some of these issues, increase coordination, more funding and resources. That's definitely always on our list. Attracting a culturally diverse quality healthcare workforce. So not just more providers, but culturally competent providers. And planning now for services needed so seniors and residents can age safely in our communities. So this is just kind of an overview of all the different sections in the community health assessment, along with the health equity index map. And this is a really handy tool that is on the Prince George's County Health PGC Health Zone website. And it's kept up to date, and it just gives an overview of where, based on a number of factors, where they think the most need is for to address health outcomes. Sorry, I lost my train of thought there. So now we'll get into the new stuff. So just kind of going over the population profile. Prince George's County is growing, and it's growing pretty quick. It's growing quicker than the rest of the state. And it's the second largest county in the state right now. But one of the populations that is growing especially quickly is the Hispanic population, and that grew nearly 60% over the last 10 years. And it now comprises almost or more than 1 in 5 residents. So we've got kind of the overall graph of the population and then demographic breakdown by race and ethnicity. And that's one thing I love about the community health assessment in general, is it tries to present information both in raw numbers. Like here we have population demographics. We can see Black non-Hispanic is our largest demographic. It's larger than that for the state of Maryland. Both of those are larger than the United States percentage-wise. Hispanic, same. White is lower. Asian non-Hispanic is fairly similar. But all of the information is presented both in raw numbers and then in nice, clean little graphs. So depending on what your preference is, there's some really nice visualizations. And then so we have a very different population makeup than the rest of Maryland and the county as far as race and ethnicity goes. But if you look at other factors like male and female gender, it's very similar. Age distribution is overall very similar to both the state and the country, except for the median age by race and ethnicity. And this I found very interesting. Hispanic, any race, was significantly lower than the other race and ethnicity groups for the county. And so here we just have a map by racial and ethnic majority. And so you can kind of see where there are counties up at the top. There's in the zip codes up at the top, there's no majority. And then it just kind of goes down through. There's areas with Hispanic majority, areas with white non-Hispanic, and the majority of the zip codes are Black non-Hispanic majority, ranging anywhere from 50 to over 80%. And race and ethnicity doesn't tell the entire story of our county, obviously. We also have a large population of foreign-born residents. And so we have graphs and numbers for this. So we have the country of origin, and then we have the languages spoken by foreign-born residents, with Spanish being the most common. And then we also have a graph here at the bottom, foreign-born residents speaking English less than very well by language spoken at home. And 81% of primary Spanish language speakers speak English less than very well at home. So that was something that I definitely thought was interesting. For income, we have overall income, but then we also break things down by race and ethnicity. And for this graph, you can see for the top earners, the over 150,000, the categories, that category is highest for Asian and white non-Hispanic. And you can just kind of see the discrepancies there between race and ethnicity and how that impacts overall income. Access to care, another kind of outlier here is the Hispanic population, where the residents with health insurance percentage is significantly lower than the other race and ethnicity categories here. But everything is fairly similar to the state of Maryland, maybe slightly lower. So that's definitely something that we need to look at addressing. And that ties into the number of providers, and both those things kind of just highlight what a problem access to care is in Prince George's County and why it continually keeps popping up as one of the #1 health issues. So kind of the next steps that we want to do for the community health assessment is to make this more digestible and tackle it piece by piece. And so we're going to be creating a number of infographics that are very visualization heavy and use plain language to describe what we're seeing and what we need to work on. And we need to explore inconsistencies. As I mentioned, some of the health disparities in Prince George's County are complicated. For example, we have excellent cancer screening rates. They're better than the state average, but our outcomes are worse. And so where's the disconnect there that's causing that? How do we collect data to show that, and how do we fix it? We will be reaching out to the different work groups to talk about the areas in the community health assessment that they'd like to prioritize, and kind of creating a health improvement plan to address some of the issues that we found. And then we will be providing regular updates on this process as well. And so here's just a link to the community health assessment, as well as a link to the PGC Health Zone website. And it has a data dashboard that has all of the information that I've shown. And it is really handy. You can, a lot of the things, depending on the data source, you can break down by zip code. You can break down by race, ethnicity. You can break down by gender. Not everything, but a lot of them really give you a granular look at the data. And one of the things that we hope to do is maybe host a training, so those interested can get more familiar with navigating that dashboard and how to find the data that they really want, because it doesn't do anyone any good if they can't access it. Okay, and then I think that is it for my little presentation there. Are there any questions? Sorry, I think you're muted.
Thank you. I am. It's not a Zoom call like everyone says, unless someone says, oops, I'm not on mute. Or a Microsoft Teams call. But thank you so much, Jake, for providing that that information. Were there any initial questions at all?
You know, I was Oh, there's a hand raised
There's a
over
hand
here.
raised.
Yeah.
Yeah,
Oh,
so
yeah, go ahead, Cynthia.
I've been wondering what's been the impact of having Capital Region open, right? Because that was supposed to be such a big impact, particularly in the southern part of the county. And I thought that they were supposed to have focus on like heart and cancer, were they not? Weren't there sort of those the two big things? And I was just wondering who, who's looking at that from the health department perspective or county administration and really seeing like what difference having that shiny new facility has made in the county. Because I arrived in the county before the groundbreaking, right when everybody was like super excited about it happening and things like that. And there was just a lot of enthusiasm, shall we say, about the difference that that one hospital was going to make. And I'm just curious, given the picture that Jake just presented, what do we know so far about what difference that hospital has made?
That's an excellent question. I know that's something that the county is looking into because that was questions on our annual audit for some of the things, but we currently aren't tracking a lot of hospital data. So that's something that we need to reach out to the hospitals, I think, and find out utilization rates. And otherwise, we're kind of just relying on general county numbers from the health assessment to determine an impact. So it is on our to-do list to reach out to the hospitals and kind of get a better idea of how they're doing and the services they're providing and the services that we think they could additionally provide or yeah, strengthen a little bit.
Yeah, I mean, like when I see the cancer data, I think, well, is it a matter that people don't know that things are available, so it's a promotion problem, or is it that this is cancer in particular is a topic that people don't really want to know about, so it's an avoidance issue, or is it that they've gone and had really bad experiences and don't want to go back because it was such a terrible experience? Is it that they get screened, but then they don't have the resources and the time to, follow through on the full diagnosis and treatment? I mean, there's a lot of different things that could be underlying, and I'm just wondering, if there are members of the coalition who might have some insights on any one of those or more dimensions.
I think I think it's really interesting. If I heard you correctly, Jake, you said that the rates of screening for cancer are fairly high. So the rates of screening, but then at the same time, when we look at the number one of the number one issues, it is still access to health care, right? And then you have all of the other factors that we found. It's going to be interesting to see the results of this COVID study and the data related to that. But I think, Dr. Bauer, your question is well taken. As the intent, as I perceived it, was to have the the hospital to increase that access to health care. And there have been these stops and starts that we have seen in certain areas of the county. We recognize one of the major areas of concern was the 20743 area. And so the question is, is the new hospital system playing a role in that, in addressing what has been studied and researched and reported on numerous times? So how are we, are there bridges that are happening to address those issues? So, Yana, I'd love to hear some of your perspective as well.
Yeah, so all data is very important, right? Thank you so much. And I really appreciate Prince George doing that. But take a look on the survey and the methodology, I think we need to find a strategy to collect more information, right? I mean, there's this, is not a good sample. I think. I mean, you guys say that. I'm not saying anything new. The report says that. And also some of the bias, like more women answering the men, more women who speak English in at home, right? So I think we just have to take into account the limitation in terms of, and maybe do some strategies even here, right? I think a lot of data is important to see who is represented there, right? I mean, I think, and also how can we make this more diverse, more widespread, how maybe to include the community health centers into this too, in some ways, to plan the assessment. I think there's room to grow. I want to just acknowledge that I'm going to use all this data no matter what, because I think data is very important. I'm really happy that the health department do this assessment. But I think as a health equity group, I think we should take a look on how can we make that kind of data gathering more inclusive? Like, how can we make this a more representative of what we're seeing in the county and make this even better? I think all the findings is already an indication where we should go. I think is great, right? We didn't see anything, but I think we'd even learn more and more in depth of some areas if we distribute the survey in a different way, include more people in this, and trying to find those who are not answering the questions, right? I mean, I think having only 12 people answering Spanish is missing a lot of the monolingual immigrants, for example, right? And then you end up having more people answering that they speak Spanish. I'm just making that kind of course, I'm guessing here too, right? Because of course I don't have, but just the comment. So in terms of the findings, I think as understanding the importance of the social determinant of health, but also access to quality, right? I mean, we're talking about people are not only assessing that there is not enough, but not enough quality healthcare in Prince George. I think it's interesting for us to think that too, and even think about how to understand what people are calling quality. Is technology, is complexity, or is culturally appropriate, right? Maybe people are not feeling that it's high quality because they don't feel welcome or the understanding of the system. Those are the few comments that I wrote here for us to keep thinking, right? Because I think those data we can move with our group forward, thinking some of those, probably how to inform a little the assessment or give some, probably take a look on the methodology when it's implemented again, and advising some of this could be something that I think as a coalition we could do.
Mhm.
I think that's an
Yeah.
excellent idea. And as we look at doing that, I mean, I know that's definitely on my radar is to, instead of having 100 and some participants, I would love to have thousands of respondents to the survey. I would also like to do some focus groups and reach out to specific populations. It's a different kind of data, but it's no less important. But I'd also love to not wait 3 years to start collecting that data as well. So I think that might be something we can look at doing in the short term as well.
Mhm.
Yeah. Yeah, those were all great comments, especially in regards to, how to ensure that we're being as inclusive as possible with not only the population, but the organizations that we're reaching out to. And then one thing that strikes me is I think, Jake, you had noted in one of the slides that it was interesting that the cancer screening rates were high, but so were I believe it was the death rates for cancer. And so I'm wondering, like, in terms of the information that we're collecting in the data, at what point in time is the screening being taken? And so I think that piece of information is also critical because and then that leads to, at what point in time are they receiving that access to quality health care so that it's not too late? Because they can be screened at a point in time when it might be too late. So does that, how can we see that information so that certain things like that can be addressed?
Mhm. Absolutely. Absolutely.
Were there any other thoughts?
And I know I think we had some additional questions if anyone wanted to, was that on the next slide?
The next slide. Right. Yeah. So here there are just a few discussion questions that um, we thought may be a little thought provoking and leading in our discussion. So if there are any of the four that are listed that maybe anyone would like to address, the one that sticks out is what role can community organizations such as ourselves and healthcare providers and other stakeholders play in addressing um, historically marginalized population health disparities within the community. Is there anyone else at who needs to be at our table discussing this or reaching out to? I know coming from a space of education, it's great that we have University of Maryland involved. But I'm also coming from a place of education in medical school. So, how can we get medical students involved in, this capacity in terms of their role? Nursing students, Bowie State Nursing School, how can we, get them involved in what they see clinically?
Well, and I was also thinking about, nursing and other programs just to increase the number of, local providers, right? So if you've got these local programs, are they graduating professionals who are staying in the community and actually increasing the capacity within the community? And is there enough, sort of work on the pipeline, right? Students cut
Mhm.
out of, you know, uh, high school into, these local programs as well so that they stay. Because I mean, I know all of us are having these struggles of like, I think my sister told me, oh, she's out in California, but she told me like she called a primary care office and they said they could give her an appointment in a year. And I said, if somebody needs a primary care appointment and they have to wait a year, they'll be dead. What's the point? Right? So we all know that we're waiting months and months and months just for basic things. And so if we're talking about screenings for cancer, behavioral health, mental health, all these things, people can't wait months and months. So, I mean, I would like to see like, just dealing with this access problem because I think we have resources here. The question is, are those resources being deployed to meet local needs, right?
Boy, I think that's such a that's such an important point. And I mean, but also the inconsistencies that we see throughout, the county, and I think it's probably really best illustrated when we talk about food, uh, the access to healthy foods, right? And I use that as a sort of an analogy when we look at the access to health. There are, uh, I'm in the Bowie Glendale area. From my house, I can walk to two grocery stores. Within 3 to 4 miles, I can probably access about 8 grocery stores within 3 to 5 miles, right? I can go 15 minutes in a different direction and not find any grocery stores, or maybe a food market or but no major grocery stores. And so as we look within the county, we see these, and the same thing I think when we talk about healthcare providers. There's certain areas that we have clusters of access and health, and then there are other areas. And so looking at how to address those kind of differences that we see throughout the county. Suyana had her hand raised. Are you?
Yeah, I was going to make a joke that in our case, this month should be the majority health, right? We just saw the data.
Mm-hmm.
There should be like the national majority health month for us, at least in a sense of what, how we, the perspective, right? And I think the perspective that what may be in other communities in the country is called minority in Prince George is the majority. I think in that sense too, understand the urgency of understanding the need for providers that are coming from the community, that are staying in the community, that get trained, that are being the pipeline on the community. I think is that we could be a very interesting lab because we have the possibility of having a pipeline of residents. There are anyhow. One thing that for me strikes, especially now because it has been for healthcare a problem to find professionals, right? I mean, we try, especially when you talk about community-based organizations, when it's really hard for example, a clinic to compete with a corporation who pays nurses and doctors and a salary that we don't receive reimbursements that or grants that can cover the salary that a for-profit healthcare system, right? And also on understanding we need more professionals because now what's driving all the salary bump is competition. I mean, that there is more demand than supply. So I think we need to be very creative is how to have more people having scholarships to become a nurse, to have scholarship to become a doctor, scholarship to become a mental health provider in different categories. And we need to, this is my perspective now because we're at the Federal Qualified Health Center, we're desperate to have more demands of providers so we can also control also this salary nonsense now. I mean, nurses, bilingual nurses now is so expensive because there's a shortage everywhere and people has to pay their loans, right? I mean, a lot of people, especially minorities, they get out of the medical school or nursing school with those huge debts. So I don't know, giving people some break on those student loans or forgiving student loans if they stay in the county. I don't know. I'm just brainstorming here, but I do think we need to start thinking on how much we would have a better and more sustainable and even healthy county if we could empower our own youth to get trained on those professions that are needed and they would stay around, right? Or they understand the population that they come from and they're going to serve as professionals. Just sorry, I had to vent a little bit.
It just reminds me of I happened to do a workshop today on talent management planning, right? And so just in terms of even looking at, and the idea is to look at creating a pipeline, of talent as that's sort of in line with the strategic plan or the vision of what is needed. And so I wonder if we have some equivalent of that, or if there's any structured plan in place to look at how can we address this need within, say, the county related to healthcare professionals. And so, what is the plan? As you're saying, you have youth who may be interested in nursing and other health related professions. What is there a talent management plan in place to help encourage and develop that talent? So I think we probably should. I think that we have some students from the Maryland Terrapin think tank here, and I want to thank Xerxes and to thank Jake for the presentation. So thank you very much, Jacob, for presenting and giving us that new information. Do we have
Yes, hi.
Okay. Is that Dan?
Yes, this is Daniel. Nice to meet everyone. Hi, Dr. Slade Martin. How are you doing?
Good, thank you. Glad to have you.
Yeah, thank you for having us to provide some updates. I thought that for those of you who may not be familiar with the Terrapin think tank or who I am, I'd like to give a brief introduction. So my name is Daniel. I'm currently a senior at the University of Maryland studying neurobiology and health policy. And next year I'll be attending medical school at the University of Maryland School of Medicine. And I'm also one of the co-directors and co-founders of University of Maryland's Terrapin think tank. So the last few weeks, we've been working closely with Dr. Slade Martin and Kim to build out the Health Equity Champions curriculum. We are a team of students that have a lot of motivation and excitement to advance health equity across Prince George's County. And our think tank is the school's first student-led policy incubator, and we're actually an official partner of the School of Public Health. So we have a lot of resources to access, faculty advisors, mentors. I actually know Dr. Latouche Howard very well, and Dr. Tracy Ziegler, if you're familiar with those two lovely professors. And also I met Dr. Bauer recently as well. So we're really deep into this health equity stuff, and this is our passion. So just to provide some updates on what we've been doing with the Health Equity Champions modules, our team has 9 people. We have since split all the 4 modules across our team, and we've been basically developing detailed lesson plans concerning the outline that you provided us, Dr. Slade Martin. So our approach basically on how to build out this module is to first develop comprehensive lesson plans based on the learning objectives outlined in those notes. So what we've been doing is we basically have been going through the document and annotating everything that you provided us. And we are jotting down things that we think would be a great way to explain these core concepts. So for example, the one that I'm personally working on is the policy, the 4th module. So I was just looking at the policy notes yesterday, and what we're doing is we're finding nice case studies from the world, talking about specific bills and saying, let's look at this bill together, and this is how we'll teach the class as to what the content actually is. So our content is very hands-on, and we are in the process of building out the content that aligns with the directives and goals of that document. So the lesson plans are centered around content-based lectures, but they include many case studies and opportunities for participation and discussion sprinkled throughout. And also, we're also prioritizing the ability to leverage these modules to be taught either virtually or in person. So we're trying to incorporate things that may be more fitting for a Zoom format, or things that may be more fitting for an in-person discussion, depending on where you all decide to take it. And this may involve how detailed the discussion is, right? If you're in person, maybe people are more willing to raise their hands and get up and talk. But if it's on Zoom, we can always adjust. So that's basically our approach. In terms of timeline, we're being very aggressive with our timeline. We aim to have an internal draft of the entire curriculum done within a week or a week and a half for our first draft for internal review. And then afterwards, we'll be sending out this content to Dr. Latouche Howard and Dr. Ziegler to, for their expert opinion and input. And then after that, we'll probably spend 2 to 3 weeks finalizing that content internally to make sure that we have done our due diligence in providing something that we are proud of. And then by the end of 3 or 4 weeks, we hope to have something that we can share with you all. The reason we set this tight timeline is because the school year is ending very soon. So we want to make sure we get everything done before we head into the summer. So I just talked a lot. So please let me know if you want me to clarify what I just said. I know I said a lot. So.
This has been really helpful. I just will open the floor up for any questions that anyone has or clarifications that anyone has about the program.
Well, thank you, David. I'm sorry. Thank you, Daniel, so much for
Of course.
providing that information. I did have a very quick question pertaining to, everyone on the team, the 9 individuals, are they all graduating? Are you all graduating?
So on our team, we have 3 people that are graduating, but there's many more
Okay.
people that are staying. So
Okay. So there'll be some fluid and continuation
yes,
with the
yes,
work. Okay.
yes.
Okay.
And
Okay.
beyond that, Dr. LH and Dr. Ziegler have a graduate student who's working closely with us. So there will be
Okay.
continuity upon my graduation. Yeah.
Okay. Okay. And congratulations.
Oh, thank you.
Okay.
Thank you.
Good question. Uh, Other questions for Daniel, and congratulations, Daniel. Um, other questions about the program, the Health Champions program, or any aspect of the programs. We had a couple new people with us, and who may not be familiar with the Health Equity Champions program. So if anyone has questions about that in general, I think Daniel can answer those questions. But we greatly appreciate what you all are doing and like the process. It sounds like the process will work well, and appreciate your efforts in getting information to us before before the end of the academic year. So,
Of course, of course.
and
Yeah,
knowing that it's also a very intense time for students and professors. So,
yes, absolutely. Our team is very excited about this project. We're very grateful that you placed your confidence in us. So we are trying our best to make sure that we can prove that that wasn't misplaced. So uh, we'll be providing constant updates. Dr. Martin will be continuing to email you and sending you more updates as to our progress. But we'll be happy to stop by these meetings and continue to share what we've been doing in the meantime. Yeah.
well, thank you. We look forward to it. If you have questions, just let us know. And just to the group in general, we'll be certainly sharing for uh, all of our review, and we'll spend some intensive time once we have the draft presented to us. We'll spend some more time, combing through that within the work group.
Sounds great.
Good. Thank you, Daniel, for joining us. Any other questions from anyone? Thank you very much.
Okay.
And
Happy
all
to see
the
you all.
best. Yes, take
Bye-bye.
care. And so what's next on our agenda? Any announcements about upcoming events or programs? Does anyone have any
So
announcements?
I will say that prior to Dr. Bauer leaving the meeting, she mentioned in the chat a really great suggestion as we're talking also about incorporating our objectives and priorities with the health assessment. She had proposed developing a proposal to the Board of Health on pipeline programming. And so maybe incorporating that, like I said, into our priorities and objectives for our committee, and continuing the conversation on the community health assessment. I think that that's a great idea.
Mhm. Yeah, that is good. Yeah.
And thank you so much, Suyana, for joining us. We see that you have to depart. We'll look forward to seeing you again.
Thank you for watching the chat. I appreciate it. I just have an announcement next Thursday, and I'll have some information sent out about it. Next Thursday at 6 p.m., the Prince George's County Community Advisory Group, which is an outreach program connected to the Kimball Cancer Center at Johns Hopkins. we are hosting, we will have a presentation on Alzheimer's disease in the Black community presented by Dr. Irene Anenye. And she is she works with the Society of Women Health Researchers, and she will be presenting next week. I'll get that information out. I think we're good. And then our next meeting. Please join us and spread the word for our next meeting on May 18th at 3:30 p.m. Zerxazer or Jacob, any other comments before we close out?
None for me. Happy to be here. I look forward to the next meeting.
Well, thank you all. Thank you all for being here. And Amber, I saw your reference to the Laurel Park in the chat. Saw that reference. So thank you all. And thank you, Regina, for joining us. CS, who was CS?
I think that was Christine.
Me?
Thank you
Is
for
she still
having
here?
me.
Yeah, so yeah,
Oh,
still here.
hi, Christine.
Hello. So I mean, I was late, so I missed missed Jacob's presentation, unfortunately. So yeah, I look forward to seeing a link or whatever gets sent out.
Well, thank you. I know you had another meeting, so thank you for getting here. Yes. All right. Well, if all is done, we'll give you back about 14 minutes, and we appreciate everyone's participation. And we had a great discussion. So, looking forward to our next meeting. Thank you all. Thank you, Jacob, for standing in for Kim. And we will all connect next month on the 18th. See you then.
Take care, everyone.
Take care.
Bye-bye.